Hi, it's Dr. Poole again, your pathologist at large. This talk focuses on the major causes of acute cerebral hemorrhage that relate to abnormalities of blood vessels. Remember, I already talked about hypertensive cerebral vascular disease, so this talk will focus on aneurysms, vascular malformations, and cerebral amyloid angiopathy. Hemorrhage can also be caused by trauma, tumor, or systemic coagulopathies, but these will not be discussed here. Remember, many features of the history and physical examination suggest certain stroke subtypes. In this talk, we'll focus again on intracerebral hemorrhage, which does not improve during the early period and progresses gradually during minutes or a few hours. An aneurysm is described as an abnormally dilated segment of a blood vessel. Remember, we talked about aneurysms in the cardiovascular system. Included in this group of CNS vascular diseases are saccular, which are congenital aneurysms, fusiform, atherosclerotic, infectious, and traumatic types. I will focus on saccular aneurysms because they're the most frequent cause of clinically significant subarachnoid hemorrhage. A saccular or berry aneurysm is by far the most common type of cerebral aneurysm. Approximately 3 to 5% of the population is thought to have some type of cerebral aneurysm, and they're about twice as common in women. About 25% of all cerebrovascular deaths are due to ruptured aneurysm. Although congenital cause is widely accepted, it's interesting that such aneurysms are rarely identified in infancy and childhood and are most commonly identified in adults older than 30 years. Multiple aneurysms have been identified in 20% to 30% of autopsied individuals with berry aneurysms. Risk factors associated with the development of saccular aneurysms and spontaneous subarachnoid hemorrhage include chronic hypertension, cigarette smoking, female sex, and African American race. There are some other well-known associations of saccular aneurysms with autosomal dominant polycystic kidney disease, Ehlers-Danlos syndrome type 4, neurofibromatosis type 1, and Marfan syndrome. About 6 to 9% of arteriovenous malformations may occur together with one or more saccular aneurysms, which is also kind of interesting. Most saccular aneurysms remain asymptomatic until they rupture. However, about 50% of patients experience mild symptoms related to an initial small bleed, known as a sentinel hemorrhage, which may occur days to months before a large subarachnoid hemorrhage. The latter is heralded by an acute severe headache and sometimes loss of consciousness. Stiff neck, nausea, vomiting, muscle weakness, decreased sensation, lethargy, seizures, speech impairment, and impulsivity may also occur. Blood in the subarachnoid space can stimulate vasospasm of the basal arteries, which can result in significant cerebral ischemia, infarction, and brain swelling. Occasionally, aneurysms may also cause symptoms by compression of adjacent structures. Saccular aneurysms typically occur at branch points in large arteries of the circle of Willis, where turbulent flow may contribute to aneurysmal dilatation. The most common locations include branch points between the anterior cerebral and anterior communicating arteries, the M1 and M2 divisions of the MCA within the sylvian fissure, and the internal carotid and posterior communicating arteries. Saccular aneurysms arising at the site of the bifurcation of the basilar artery into the posterior cerebral arteries account for just 4% of cases. A saccular aneurysm consists of a thin-walled sac-like structure that is attached to an arterial branch point via a narrow neck. The sac may be spherical, oval, or lobulated, and the multiple aneurysms may be present. The rupture site is usually apparent at the apex of the sac. If the bleeding point of the ruptured aneurysm is oriented toward the cerebral surface, hemorrhage under arterial pressure dissects into the brain parenchyma and may extend even into the ventricular system. Most saccular aneurysms are between 0.1 and 2.5 cm in diameter. The image on the left is a gross specimen showing the base of the brain and the location of two saccular aneurysms. The one at the top involves the anterior communicating artery, and a second one arose from the branch point of the internal carotid artery and the middle cerebral artery. On the right, gross dissection of the circle of Willis shows the same two saccular aneurysms. Note the lobular appearance of the aneurysms, which gives it its colloquial name, Berry aneurysm. Ruptured aneurysm is typically associated with extensive basal subarachnoid hemorrhage. If the bleeding point of the ruptured aneurysm is oriented toward the cerebral surface, hemorrhage causes dissection into the brain parenchyma and may extend into the ventricles. With prolonged survival, organizing basal subarachnoid hemorrhage may obstruct flow of cerebral spinal fluid and cause hydrocephalus. This image shows extensive acute parenchymal and ventricular hemorrhage caused by rupture of a saccular aneurysm. The rupture site was obviously oriented toward the brain and dissected into the lateral ventricle. More commonly, ruptured saccular aneurysm results in extensive basal subarachnoid hemorrhage, as occurred here. Microscopically, the aneurysmal sac may contain thrombotic material and fibrocalcific atheromatous plaque material. The junction between an adjacent normal artery and the aneurysm neck will show loss of elastin fibers and smooth muscle, with the neck ultimately being composed of hyalinized collagenous tissue. The blue arrow shows on this elastic stain retention of the elastin fibers, and the red arrow shows loss of elastin fibers in this bulging pocket of the aneurysm. Vascular invasion by infectious organisms and the associated inflammatory reaction in the wall can lead to focal dilations of cerebral blood vessels and symptomatic hemorrhage. These are referred to as mycotic aneurysms, although these lesions may be caused by bacteria as well as fungi. Why they're called mitotic, I don't know. You'd have to ask Willis. They account for 3 to 5% of all intracranial aneurysms and may rupture and result in subarachnoid hemorrhage or multiple hemorrhagic infarcts with disseminated disease. Vasoinvasive fungi, such as Aspergillus species, that directly invade the vessel wall may cause thrombosis and hemorrhage. Vascular malformations are traditionally classified into 4 groups: arteriovenous malformations, cavernous angiomas, capillary telangiectasia, and venous angiomas. The basis for classification takes into account the caliber and configuration of the component blood vessels, the relationship of abnormal vessels to brain parenchyma, and the presence or absence of arteriovenous shunting. I will further discuss AVMs and cavernous angiomas. Capillary telangiectasia and venous angiomas are much less common, as well as less likely to bleed. AVMs are the clinically most important brain vascular malformations. An AVM is defined as a tangled mass of abnormal arterial and venous channels without intervening capillaries, which are typically separated by gliotic brain parenchyma. They account for 1.5 to 4% of all brain masses, with a peak incidence in adults between 20 and 40 years of age. In one large study, the mean age at diagnosis was 31 years. The incidence is approximately 0.14%. Men and women are affected equally. Most AVMs are supratentorial and occur within the distributions of the major cerebral arteries. About 50% of patients present with a cerebral hemorrhage, and this finding is typical of younger individuals. Some patients may experience a subtle onset of hemorrhage or focal neurologic signs. Progressive symptoms may be encountered as the AVM grows slowly. This progressive enlargement probably involves the development of collateral arteries and veins. Large AVMs produce ischemia of surrounding brain tissue because of the steal phenomenon. Seizures may occur in 25% of patients with supratentorial AVMs, especially in older individuals. Grossly, the surface of the brain in the region of an AVM contains dilated, thick-walled vessels which represent draining vessels of the lesion. On cut surface, AVMs consist of a tangled mass of blood vessels of varying diameter and wall thickness. There may be evidence of remote or recent hemorrhage or both. Superficial AVMs tend to have a broad base near the cortical surface where they drain into surface veins, whereas deeper lesions drain into the deep venous system. This is an AVM seen on the from the superior aspect of the vein over the left posterior parietal surface. Most occur in a cerebral hemisphere in the distribution of the middle cerebral artery. This is the gross appearance of the cut surface of a large AVM arising in the region of the Sylvian fissure and extending toward the lateral ventricle. Microscopically, the variability in size and configuration of the abnormal blood vessels is usually quite striking, which you'll see in the next picture. In addition, a characteristic feature is the presence of gliotic CNS tissue located between abnormal blood vessels. Arterial elements may have variable amounts of smooth muscle proliferation, collagen deposition, and reduplication of the internal elastic lamina, whereas large arterialized veins are thick-walled and collagenized. Thrombosis with varying stages of recanalization and sometimes calcification may also be present. This image shows 3 profiles of thickened blood vessels that are separated by this gliotic brain tissue. This is a low-power image showing thick-walled arterial and venous vessels of varying caliber and thickness, characteristic of AVMs. Cavernous angiomas arise most commonly in young adults with a slight male preponderance, but about 1/4 of patients are children. The annual incidence is estimated at 0.4 to 0.5%. These are defined as an abnormal, compact collection of thin-walled vascular channels without intervening brain parenchyma and peripheral hemosiderin. Cavernous angiomas may occur anywhere in the nervous system and leptomeninges, but are supratentorial in 80% and infratentorial in 20%. Most typically cause seizures when the cerebral cortex is involved. 1/3 of patients present with focal epilepsy. The annual risk of acute hemorrhage is about 1%, so surgery is performed to control seizures and to reduce the risk of hemorrhage. Now, in contrast to AVMs, cavernous angiomas have no direct arterial contribution. They consist of a compact mass of dilated, thin-walled, variably hyalinized vascular channels with little intervening brain tissue. There's no muscular hypertrophy or elastic lamina, but vessels may be calcified or thrombosed. The surrounding brain tissue is gliotic and shows evidence of remote hemorrhage with scattered hemosiderin-laden macrophages. Cavernous angiomas may occur together with venous angiomas or capillary telangiectasia. Occasionally, patients with cerebral cavernous angiomas may have similar vascular lesions in other organs such as the kidney, liver, lung, or skin. Since these are rarely resected in total, imaging is the best gross pathology. This image shows a classic lesion with a central irregular enhancement corresponding to vascular flow voids, and peripheral hypodensity consistent with hemosiderin deposition. You can see the lesion right here. Low magnification shows a cluster of dilated thin-walled blood vessels, again without intervening brain tissue, and this is a key histologic finding which separates it from an AVM. Finally, there's cerebral amyloid angiopathy. Cerebral amyloid angiopathy predisposes patients to large lobar hemorrhages, which is why it's talked about here. And this accounts for 12% to 15% of all cerebral hemorrhages in the elderly. This is a disorder characterized by deposition of beta-amyloid protein in the walls of cortical and leptomeningeal arteries, which predisposes patients to spontaneous lobar hemorrhage. The disease should be considered in any older, non-hypertensive adult with spontaneous intracranial hemorrhage. Clinical symptoms reflect the anatomic extent and location of the hemorrhage. Lobar hemorrhage can occur acutely as a massively acute stroke, most often involving the frontal or frontoparietal regions, or as recurrent hemorrhagic infarctions that take place over a period of years. The incidence is about 0.2% in patients over 60 years. It's most common in patients older than 60 years, and men or women and women are equally affected. The symptoms reflect the anatomic extent of hemorrhage and the range of massive lobar stroke to progressive dementia. Parietal lobe involvement may result in a curious phenomenon called neglect syndrome. Commonly, cerebral amyloid angiopathy is found in demented individuals and is associated with Alzheimer-like neurofibrillary pathology. In contrast to the deep cerebral hemorrhages of chronic hypertension, hemorrhages associated with amyloid angiopathy are more peripheral and involve the cerebral cortex and adjacent structures. One can often find multiple cortical and subcortical hemorrhages of different ages. If you recall, amyloid is a pathologic protein which is caused by abnormal folding, producing an extensive beta-pleated sheet secondary structure. In this conformation, protein polymers form highly insoluble fibrils. These fibrils are deposited in the walls of arteries and arterioles of the cerebral cortex and meninges, as well as in other organs. On routine H&E staining, affected vessels show mural thickening and loss of the arterial architecture because of accumulation of acellular homogeneous eosinophilic material. Capillaries and veins are less often involved for reasons we don't know, and blood vessels of the deep white matter are typically spared. Arterial and arteriolar amyloid accumulation initially appears in the basement membrane around smooth muscle cells at the peripheral aspect of the media and adventitia. There is progressive destruction of smooth muscle cells, but generally sparing of the endothelium until late stages of the disease. Affected vessels become rigid and fragile and often assume a rounded or, quote, double barrel contour. Some vessels ultimately undergo fibrinoid necrosis and rupture with hemorrhage. Vascular amyloid accumulation is also likely to alter the function of arterial and arteriolar autoregulation. Characteristically, you find apple green birefringence of amyloid under polarizing microscopy, or you can demonstrate the abnormal protein by immunohistochemical methods. This is an image showing an irregularly thickened leptomeningeal artery with effacement of normal vascular structure by amorphous eosinophilic, or in this case is kind of purple-looking material. Note the perivascular hemosiderin deposition in the green circle, which are the chunks of dark brown or black material, which suggests previous hemorrhage. There's marked thickening with pink hyaline material of a small peripheral cerebral artery seen in the right, with leakage of red blood cells around the vessel. The amorphous pink amyloid within the medium-sized arteries in the left panel has weakened the vascular walls to allow extensive microbleeds, which can lead to more extensive lobar hemorrhage. Finally, as I mentioned, you can use immunohistochemical stains that target the amyloid protein, here showing positive staining around cortical arteries, as well as several neuritic plaques. Cerebral amyloid angiopathy also often occurs together with the neuritic plaques and neurofibrillary tangles associated with Alzheimer's disease, which we'll talk about in one of the future cases. So to summarize, this talk focused on intracranial hemorrhage as related to abnormalities of blood vessels. This includes aneurysms, and I talked about saccular aneurysms, arteriovenous malformations and cavernous angiomas, and finally, cerebral amyloid angiopathy. Sorry that there was so much pathology material in this case, but this is all essential stuff for you to know moving forward. There will be less but variable amounts of pathology content in the upcoming cases. But this is the most important stuff. So good luck, and please email with any questions. I also plan to try to schedule more time going around to the CBCL questions, so you can always catch me there as well too. Thanks.